Welcome to ST3 Hacks. This podcast is for you if you're preparing for the UK Trauma and Orthopaedic ST3 National Selection Interview. I've been through the cycle myself and ranked high enough to take my preferred post in the Royal London Major Trauma Rotation. This series is me going through my experience topic by topic to help you structure safer, clearer, and more confident interview answers. Today we're going to start with the upper limb and specifically distal radius fractures. How I frame distal radius fractures. When an interviewer gives you a distal radius fractures, they're not testing memorization. They want you to know whether you can assess stability, recognize the red flags, and tailor the best practice management to the patient. Before we get into answering the question, let's recap the pathoanatomy, classifications, guidelines that you should be aware of. So, a distal radius fracture involves the metaphyseal region of the radius and often affects the distal radial ulnar joint. I don't dwell on classifications here because their value is in describing the injury, not dictating treatment, but you can be aware of the Frykman classification because it's quick and easy to communicate. It's types 1 through 8. Odd numbers are escalatory in nature, going from extra-articular, intra-articular with radiocarpal joint disruption, intra-articular with DRUJ, i.e. the distal radial ulnar joint, or intra-articular with both the radiocarpal and distal radial ulnar joint. The even numbers are associated with an ulnar styloid injury in addition to those pairings. Have a look at a table. It's pretty straightforward. I don't think you'll actually need to use it, but it's knowledge to have in case you feel comfortable enough to drop it. The radiographic assessment. So you normally request a PA and lateral view of the wrist, and you need to really anchor yourself to the normal parameters because that's how you justify your decisions, both post-operatively or even post-manipulation. So the combination here is 11, 22, 11. So on the PA, it's radial height should be around 11 millimeters. Radial inclination is about 22 degrees. And on the lateral view, normal volar tilt should be about 11 degrees. Now, a plus or minus of 5 degrees is normally acceptable. And there's one other thing that you need to know is the articular step-off. So the articular surface between the radius and the carpal joints should be very smooth. And if there's a step-off of more than 2 millimeters, that's a problem. So anything less than 2 is acceptable. If these parameters aren't restored after reduction, especially in younger or high-demand patients, it should push you towards operative management. Now, associated injuries with distal radius fractures can happen, and the common ones include TFCC injury, which is the meniscus-like structure in the ulnar aspect of the wrist, which absorbs shock and stabilizes the joint. The other injury is the distal radial ulnar joint, so if the ulnar is lax and is moving in a plane, that's unstable. Moreover, the ulnar styloid fractures, like I mentioned in the Frykman classification, the even numbers, if there's an injury there, and the carpal bone injuries, the capitate or lunate, can sometimes rarely be injured. Recognizing these injuries early prevents missed pathology and long-term dysfunction. And when you're starting out this case, you need to outline the key concerns and red flags very early on. So the case needs to be answered by saying many distal radius fractures are silver trauma presentations. So I would make a point of saying that I would actively look for other injuries, consider head injury and anticoagulation, exclude open fractures, and document neurovascular status carefully. Saying this out loud shows situational awareness beyond the wrist alone. Now, the guidelines and evidence that you need to be aware of for distal radius. You should start something like, I'd manage this patient in line with BOAST best practice guidelines for distal radius fractures from 2017, as well as BSSH guidance, which is the British Society of Hand. And management is largely guided whether it's intra-articular versus extra-articular, and also by patient age and functional demand. So broadly, in patients over 65, non-op management is first line for dorsal fractures, unless there's neurological compromise or gross deformity. In patients under 65, normally you're guided by restoration of the radial height, inclination, volar tilt, and articular congruity, okay? And special things like function and high functional demand. Volar displacement generally implies instability and often requires an open reduction and internal fixation. Timing of the surgery is also outlined in the guidelines. So in terms of timing, intra-articular fractures should be ideally treated within 72 hours and extra-articular fractures within 7 days. This balances the fracture biology with tissue recovery. The other research heavy thing that you should be aware of is the DRAFFT trial. So the DRAFFT trial was published in 2014 and is worth knowing. It showed no significant difference in functional outcomes between K-wire fixation and volar plating in adults presenting with 2 weeks of injury. So hand surgeons don't like it that much because the plates are not getting used, but around 450 patients were included, and the outcome measure was that patient-rated wrist evaluation scores showed a similar outcome. So the key message is the plates aren't necessary and that fixation should be individualized based on fracture pattern and patient needs. Okay, so when you start the case after you've outlined your key concerns, the relevant guidelines you're going to be aware of, you're using into this case, you should start by saying my history would be structured and focused, and I would ensure to take a mechanism of history, pain using Socrates, hand dominance, occupational function demands, smoking taste status, and relevant social factors. I'd also take an ample history, particularly on anticoagulation, as these directly influence management actions. So there you've got like a good spiel that can reel out quickly and cover all the major things that are required in this distal radius case. For the examination, you should start by saying, I would examine in a look, feel, move manner, but I'm meticulous with neurovascular assessment. I'd assess capillary refill time, radial and brachial pulses, medial, radial, and ulnar nerve function, and the OK sign to assess the anterior interosseous nerve. I'd also assess for DRUJ instability. And if there's a radiostyloid fracture, I'd also think about higher energy mechanisms. I'd also actively exclude a scaphoid fracture by checking for anatomical snuffbox tenderness and performing an axial compression test. So these are sprinkles to add in to think like, okay, this guy's not getting focused only on the distal radius, and he's a very high candidate that he's thinking about other things that can go on around the wrist. Okay, cool. But the investigations, you should ask, along with the standard PA and lateral x-rays of the wrist, I'd consider a CT scan if the fracture is complex or comminuted and interarticular, as that would guide surgical management. In higher functioning patients, in an outpatient setting, an MRI would also be considered for TFCC injuries, which occur in up to 40% of distal radius fractures. Now, moving on to management. This is big. So you should start by saying, I would manage this patient in line with BOAST and BSSH guidance. After a thorough history and examination, I'd reduce the fracture in a neutral position with a hematoma block in a safe place in A&E with the appropriate tools necessary. I'd immobilize it in a below elbow back slab with 3-point molding. Ensure effective analgesia as per NICE guidance, using oral analgesia, a hematoma block, or IV regional anesthesia. These are the things you can say whatever you've used or want to use. I'd always repeat post-reduction x-rays and redocument neurovascular status. Now, these little things at the end show like a complete surgeon, and you will stand out amongst your candidates. So, if this represents a fragility fracture, I'd also refer the patient to bone health or fracture liaison service. So it's showing holistic surgical management. In terms of operative options, you should say, after taking a detailed functional and medical history, I'd discuss operative options with the patient and talk about manipulation and anesthesia with or without KY fixation, including Kapunji technique. So read about that. It's basically where you can lever arm the bone fragments with a KY, and it's something good to know. Shows that you have knowledge of what's actually you need to do. Or I'd also consider an ORIF, which is open reduction and internal fixation. The choice would depend on fracture stability, patient age, and functional demand. In terms of the consent, they may ask you follow-up questions if you're doing really well. When consenting, I'd separate the risks into general and procedure specific. General risks would include pain, infection, bleeding, neurovascular injury, DVT or PE, stiffness, malunion or non-union. Procedure specific would include metalwork irritation, KY migration, chronic regional pain syndrome, which is a very rare scenario, 1 in 100,000, where you get hyper sensitivity of the nerves around the injury, and the possibility of further surgery and failure. So it's clear, honest, and consent is essential for patient-informed consent. And then the basic takeaway here is if you remember that distal radius fractures at ST3 level, you need to structure your answer, prioritize safety, and individualize management. That's all you really need. So that's it for ST3 hacks for distal radius fractures. Next, I hope to cover more high-yield interview topics and break them down for you in time for interviews in March and April. Stay tuned. Thank you.